impressed. It worked.
You could the same pick up.
Sorry?
They could the same pick up.
Remarkably good, actually. Did you hear it the other night when we were testing it?
Yeah, I did.
there anything in particular that you would like me to say whilst testing this microphone?
Testing, 1, 2, 3 is usually a good start.
I think if I just talk slowly and hold the conversation.
That works nicely, thank you very much.
Morning, everyone. Thank you all for coming on a Saturday morning. I'm Ben from Tech UK. There's quite a few familiar faces, so I'm sure many of you now used to work for Diabetes UK and JDRF, so nice to see many of you again, and welcome to anyone else that I don't know. Tech UK, as a brief overview, is a membership organisation for technology companies, and generally our mission is to make the UK a great place to do tech, but also make sure that technology is doing good for the UK. And I think this event really fits into both of those categories. So there are roughly 400,000 people with type 1 diabetes in the UK. If no one minds, can we do a quick show of hands? Anyone who's either got type 1 or has family with type 1 in the audience? So pretty much everyone, so it should be well, I suppose the first thing to say is you're in the right place. Unfortunately in the UK, whilst we're quite lucky if you look internationally at different healthcare systems, but of those 400,000 people, the vast majority are not getting particularly good results. It's probably also worth saying that they could get better results if they had access to technology that exists today. That technology is coming thick and fast, so we need an agile system that allows people access to the technology to manage their condition at the right time and before it's obsolete. So I'm hoping that with the people we've got in the room today, we can make some progress towards that. So quick thank yous. Firstly to Partha, who's been a great champion for people with type 1 in terms of access to tech. To Tim and Co, Tim who's live streaming from the back. So just to warn everyone, don't swear. And don't say anything.
Or at least not too loudly.
Also to the companies that are here who've given up their time to talk to us, and to some of the charities, not-for-profits, patient organisations who are also here and helping to drive access. That's really my brief intro, other than a few very boring things that I have to cover, which is, firstly, there are no fire alarms planned, so if the alarm goes off, there is a fire. This is the site of one of the greatest fires in history, as many of you will know. So you will see me donning an luminous yellow jacket. Don't use the lifts, follow me out of either of these doors, down the stairs, and turn right outside of the main doors to the assembly point. Hopefully you've all found the tea and coffee machines. The toilets are just next to the lifts. And lunch is going to be served at 12:30. I'm conscious that there are a lot of dietary requirements in the room, so just to say, unfortunately it's just a standard sandwich order, but this area is great. If you can't buy the food that you need in this area, you're probably going to starve anyway, so yeah, something we can look at in the future in terms of slightly more specialist niche, I would say. One more thing that I'd like to say is that what we're here to do to a degree is to challenge the status quo. We recognise that the current situation isn't good enough. It's not good enough for the taxpayer, value for money's being compromised, but more importantly, health outcomes could be improved. How we challenge that status quo is what we're here to talk about. But it's important that we recognise that involves lots of different parties. It involves people with health conditions, it involves companies, clinicians, researchers, not-for-profits and others. So I think if we can just start by recognising that we're all working together towards the same thing, and let's just hold this event, it's the first one we've done, with a tone of respect, recognising that we're coming from different places but trying to achieve the same things. I think that's probably all from me, and I'll now pass you over to Partha's very capable hands. Thank you.
Good morning, everybody, and thank you very much for coming along to this first event. So it started from, I think, a few thank yous to our American cousins, I must say, because I was at the American Diabetes Association last year, and I went to one of the events, and I saw an event where you had patients talking about technology, innovations that were bringing through. Companies were there, and one of the things I also met Dana, who's here in the audience. Dana, hands up, where are you?
Very back.
There you go, right in the back. So I heard a little bit about what they did. I knew about Kevin and his work. I knew about Tim, about the work he did. I mean, you can't miss his tweets, really. So I thought, well, why not do that in the UK and see how it goes? Try and bring industry and charities, clinicians, and most importantly, people who live with type 1 diabetes together. What's possible? What's not possible? Because there are some things there'll be worries about from a healthcare professional point of view. There are some things which companies may not agree with, but this is a good forum to have that discussion. And as Ben mentioned, I think we're all adults enough here, and we're not on Twitter, so you don't need to get really angry from behind a keyboard. You all know each other. Face to face, it's very difficult to be rude, you see. So, which is one of the reasons we have done it here. So, if you have got a question, ask, just like you'd ask another adult, without getting angry or sweary or the rest of it. And we are trying to change the landscape for type 1 diabetes, but NHS change takes time, and you all know that. And everybody who's been here living with type 1 diabetes knows that. In spite of that, we provide much better care than a lot of places in the world. I don't know, it doesn't feel like it sometimes, but we do. We do a lot of good work as well, but there's a lot to improve as well. So that's the sort of focus of the day. I'm not going to spend too much time on it. However, there's one thing I did want to say, since this is being live streamed as well. I've got a few queries yesterday and today about how much money we have earned of this. So I think it does need to be made clear. The 5 companies who are here exhibiting have kindly contributed to help us run this day, make it free for everybody, lunch, etc. And I did a talk for the British Dietetic Association back in, I can't remember when, and they kindly contributed to a charitable fund so that we can use that money to fund Dana from flying across from Seattle and staying over and being a part of this day. There's been no money earned by any of the speakers. I haven't earned a single penny or bought a yacht. None of us have. So I thought I would just make that clear for people who would like to know about that, because we've had those queries about what's going on, but that's fine. So without further ado, I think we'll probably start off the day. And Ben, you might need to help me a little bit here. So we are moving into the session from the companies, if I'm correct?
Yeah, so I'll bring up the slides. I think Abbott are the first company to speak in.
So I'm Mark Chow from Abbott Diabetes Care. I'm the head of R&D in the UK here, and I should maybe introduce and say Abbott does pay me. So I thank them very much for that, to be honest. So Abbott has a long history of innovation in the diabetes monitoring space. Abbott Diabetes Care was formed from 2 innovative startup companies that were acquired by Abbott, by Medisense, which was bought by Abbott in 1996, which is the first company to introduce an electrochemical glucose test strip, and Therasense, which was bought by Abbott in 2004, which had the wired enzyme technology, which is the basis for our Navigator product, and now the Freestyle Libre product as well. So over the 30-year history of those 2 companies and now Abbott Diabetes Care, there's been numerous innovations in the space of home blood glucose monitoring, of hospital glucose monitoring, of sensing, and now of Freestyle Libre, of flash glucose monitoring, introduced in 2014. So for those of you, I think you probably are pretty familiar with the system, but it is a sensor system that's designed to address some of the inconvenience in both blood glucose monitoring and sensing, and it's a small sensor that's worn in the back of the arm for 14 days. It requires no calibration by the user, and it automatically measures and captures and displays glucose readings. And with each scan of the reader over the sensor worn in the back of the arm, the user sees their glucose reading, an arrow which indicates which direction the glucose has been heading, and then the last 8 hours of glucose history information. And then each time the user uploads their device to the Freestyle Libre software to look at the data management reports, that data is de-identified and sent to a secure server, which we can use to look at some real-world data. I'm going to spend the rest of of my time here talking about some of that real-world data. I think there's some very interesting findings there that we can talk about. So this is data that was just recently published in 2018, and it comes from our first 50,000 or so users of Freestyle Libre. And that data showed some very interesting things. First of all, people use the device. They use the device a lot. So we see an average scanning of 16 times a day. And 50% of users, the interquartile range, are scanning between 10 and 20 times a day. So people are really using the device. They're interacting with it a lot. And then if we look at how people are doing, this is real-world data. So the folks, the more they scan, the more they look at the device, the more they see their glucose readings, the lower that their estimated A1C is. So from folks who are scanning in our the bottom 5% of scanners, they are having average glucose and estimated A1C of 8%. We see a drop of 1.28% to those folks who scan at the highest frequency of our distribution. You can see it goes out to a tremendous number of scans per day. And interestingly, not only do we see a decrease in average glucose, but we see a decrease in hypoglycemia in minutes per day, less than 3 millimoles. And it's the same if we cut the glucose data at a different level. We see a strong decrease in time in hypoglycemia with an increasing scan frequency by the users. So this was the initial cut of the data. It's been published now. It's about the first 50,000 users. People wonder whether those are the early adopters, the people who are paying for it exclusively out of their pocket. So the database has now grown significantly. So what I'm going to share with you is data that was shown just last week at the ATTD meeting in Vienna, and out of a database now of 237,000 patients, 1.5 million sensors, 1.8 billion glucose readings. So big numbers, pretty amazing database that we can just begin to mine. So here we see the same sort of trend. So now each dot here represents about 12,000 individual users. So we see here the results, again, 240,000 readers, which equates to probably 240,000 patients. And we see that same trend of decreasing average glucose, decreasing estimated A1C with increasing scan frequency, and a decrease of 1.5% from our least frequent scanners to our most frequent scanners, and that same reduction in hypoglycemia of a third, from 37 minutes to 25 minutes a day for users who scan from least frequent to most frequent. And interestingly, if we look at hours per day in target, so time in target between 70 to 180 or 3.9 to 10 millimoles, we see that there's a huge increase in time spent per day between those less frequent scanners to more frequent scanners of a 43% increase in time in target. So pretty amazing data that's starting to come out of this huge database of real-world data. And if we look at the device, if we look at that data a little bit differently and we say, well, how do folks move longitudinally as they start to use the device? We've cut the data in a slightly different way. So looking at a subgroup of those same folks where we had 6 months of data using the device. So here we have about 7,000 patients and more than 80 million readings. We can start to look at some other trends there. So if we look at, well, first we can see how often do people scan, and are they still scanning those frequencies? So here we see from days 0 through 180 days, they start off scanning about 20 times a day and very quickly plateau at about that same 15 times a day. And if we look a little more closely in the beginning, we can see that if we look just over the first 2 weeks, they're actually starting to scan at about 27 times a day. Here, everybody look at my reading, it's exciting, but it's they keep that rate up, and they pretty quickly plateau at about that 15 times a day. So just it's interesting data that starts to come out of it, and it's sustained throughout the 6 months of wear, and it's really echoes exactly what we saw in the IMPACT study, which looked at the use of Libre in people with type 1 diabetes. So 27 scans a day, plateauing at about 15 scans a day. And if we do an interesting analysis where we take those 1/3 of patients who showed the highest risk of hyperglycemia just by saying in their first 2 weeks of sensor wear who had the most hyperglycemia, so if we just segment that third of folks who had the highest hyperglycemia going into the use of the device, how does it evolve over the 6 months? So we see there's an 8% improvement in the time spent above 10 millimole over the 6 months, and the most dramatic decrease is in the first 2 weeks of using the device, and it quickly plateaus and stays at that level for about 6 months. Interestingly, if we segment those same folks into those are high, medium, and low scanners, so just the top third, the medium third, the bottom third, we see that there is sort of a dose response, so that the lower frequency scanners get the least benefit, and the higher frequency scanners get the most benefit in hyperglycemia reduction. And then interestingly, if we do the same thing for hypoglycemia risk, so we take those folks who in the first 2 weeks of using it, over the 6 months, the first 2 weeks had the highest number of minutes in hypoglycemia, time below 70 or time below 70. We see a tremendous reduction, a 23% reduction in time below 70. And we also see that, again, the majority of the change takes place in the first 2 weeks of using the device, and it's sustained throughout the 6 months. And interestingly, here we don't see a strong dose dependence, that if you divide into high, medium, low scanners, they all show about the same benefit. So what is clear is that people who use the device and interact with the device see improvements in their glucose levels and in their A1C and in their hypo and hyperglycemia. So we've been very interested in making it as easy as it can be for folks to interact with the device. It's in keeping with the spirit of Freestyle Libre, the first factory-calibrated 14-day sensor. And we've introduced recently the Freestyle Libre app, Freestyle Libre Link app. And what that does is allows you to scan with either iOS now or an Android smartphone that's NFC enabled to scan the sensor directly and get the readings directly on your smartphone, so rather than having to use a reader. And what this happens when you scan with the Libre Link, with Freestyle Libre Link, is that the data automatically goes up into the cloud servers. So Libre View is a cloud-based, web-based data management reporting software tool that the data automatically goes in there, can be viewed by the patient, by their HCP. And we've also introduced the Libre Link Up app, which allows a caregiver, a parent, a loved one, to in real time see the scans that their loved one does on their Libre Link Up app as well. And then again, in keeping with new technologies that help reduce the burden of diabetes, we announced last year our partnership with Bigfoot. I think a lot of you in the room will be familiar with them, which allows the data from Libre to get paired up with the smart insulin delivery technology that Bigfoot's developing in terms of smart pens and smart pumps. And we're very interested in how that collaboration move forward and, again, help reduce the burden for people living with diabetes. So with that, I thank you all for your time and hope I've given you a little bit of interesting food for thought and start today's conversation moving.
Thank you very much. Thank you. Probably the best thing to do is take questions right at the end.
Of course.
Everybody's done, so they don't have to get in rather than focus on any particular one. Everybody's happy with that, unless so we'll go on with the talks. Who's next up? Come on then. Donald French from Dexcom. Is that right? You did. Where's the surname come from?
It's French.
Apparently. It's not even all there. Yeah, it is, isn't it? Sensitive. What? Forget my European roots. Yeah, very sure. So we're just buffering while we're here.
So, ladies and gentlemen, my name is Donald French. I'm the Market Access Manager with Dexcom. Thanks.
Can you get by the mic, please?
Yes. Pardon?
Can you get yourself by the mic?
Sorry, I like to wander. I like to walk around a wee bit.
Is this a French thing?
It's multitasking. So, we got posed some questions from Ben for these presentations, and hopefully I'm going to go towards answering some of these questions for you today. So, first of which is just to give you a quick overview. Where's mine? A quick overview of one of our technologies. As I'm sure many of you are aware, and you're probably more aware than me, of the functionality of the G5 mobile system. This is one of the only real-time CGMs that removes the need for finger sticks to make treatment decisions. Now, as you guys are more than aware, there's three main components to the G5 mobile system, and that is the sensor, the transmitter, and the receiver. The receiver can also be on a phone that communicates your glucose readings, glucose levels with alerts and alarms, glucose ranges and trends. Now, one of the key pieces of functionality about the G5 Mobile and Dexcom systems is this functionality of the share function. This is one of the only CGM systems that gives you the ability to share your data with 5 key individuals. This is supporting you, hopefully, as people with diabetes, with your network of care, so that these people can have a stake, can have the information that you have to be able to support you with your diabetes. And this is a very, very important platform, because if you can't respond, or if for some reason your alarms and alerts aren't signaling for you, they will maybe be signaling for, hopefully be signaling for these people that you choose to share your data with. Obviously, we've got our Clarity-based website that is for home users and clinicians to review and analyse and evaluate historical data for making treatment changes. But alarms and alerts are an incredibly important part of real-time CGMs, because it's that audible signal, it's that signal that you need to take action. And we know from our alarms and alerts, this was a survey of 222 type 1 diabetic people, 70% of these people reported waking up once a week in response to a low glucose alert. However, 42% of these individuals reported waking up, patients reported at least once in the last 6 months that Dexcom CGM alerted someone or someone around them in response to their hypo alarm when they could not respond. And I think that is very, very important data, and one that shows the value of alarms and alerts for real-time CGMs. However, something we're very proud of at Dexcom is our accuracy. There's no point having alarms and alerts on any piece of technology if you're not accurate. We have an MARD of 9% overall, and in low range it's 12%. Now, I would stress to the whole audience to really check your low range accuracy with any of your devices, because accuracy, I've spoken to a number of people with type 1, but also the data tells us that accuracy is an absolute key thing that people are looking for, because the more you can trust in the data that you're getting from your particular piece of technology, the more you're going to trust in the treatment decisions that you make. And that leads to better diabetes management and better quality of life for people with diabetes. So, one of the tougher questions that we got asked from Ben was to address what are the challenges to uptake in the UK. And Partha has already alluded to that technology develops very, very quickly. And when we look at HTAs, and this just isn't a UK problem, this is a European-wide problem, that technology evolves so quickly. Can the HTAs really, the health technology assessments, can they really keep up with this rate of change? Now, NHS England and the devolved nations as well, and NICE and many European bodies are working very, very hard to address this point. I think we're very lucky that we've got bodies that are really listening to this and trying to put a framework in place that lends itself more to what technology and the outcomes of technology that can deliver. So, cost versus value. This is something that, it's we really have to be careful of not just taking one product and taking the actual acquisition, the purchase price of that product, and comparing it directly against the purchase price of another product. We absolutely have to look at a different metric to look at the value of what a product can deliver. And really, by analysing this relationship between outcomes and value, can we move towards more of a value-based healthcare model that does drive efficiency through the system and supports the sustainability of healthcare delivery, which I know that's something we're all very interested in. So support the user as well. There was the Deloitte report, 2017, told us that in the UK, 81% of the population now use a smartphone. I was staggered at that. And I know NHS England and the rest, and the developed nations are really trying to harness this. And industry and healthcare have got to work together to make sure that we can support people with diabetes and clinical teams really to be able to harness the technology and have the skills that means we can derive the greatest benefit from that technology. And that's something at Dexcom we're very aware of. So, increase this, and as I said, this focus on health, not illness, Now we are making steps towards this. We've had the right care pathway, and we've got Get It Right First Time initiatives. These are good initiatives that are supporting you guys, that are supporting a change in healthcare delivery that we work very closely with and try to work through as well. So, what can the NHS do to support uptake? Well, for me, it's look at novel funding pathways to support healthcare providers to be able to give people with diabetes real-time CGMs, so that they can derive the benefits that can give them. It's about supporting the integration of a value-based healthcare model that harnesses the outcomes of real-time CGM, and will aid the improvement of quality and efficiency in healthcare systems, and again, the quality of life of people with diabetes. If we do that, population health increases, the sustainability of healthcare increases, and it's really not focusing on that cost of the products, it's focusing on the outcome that these products can derive, and outcomes that they can give you as a diabetic community. And it's that we need to cost, and it's what is the value of that information that all these technologies can provide you guys in making these treatment decisions. Because if you can make treatment decisions by yourself, it will support you in staying well in this environment that you want to stay well in, and hopefully reduce potentially costly hospital admissions. So we were asked to say where we were reimbursed across in the areas that we work in. Well, there's quite a few of them. But what I will say is I'd like to echo Partha's comments that I work in a number of these countries, and we are very, very lucky in the UK with the NHS that we have, that it is free at the point of access. And there's not many countries that are up here that can say that. And there's either a co-pay or there's something else. So it's so the NHS really is, we're very lucky to have it. So that is the end of my presentation, and happy to take questions. Hopefully I can answer them.
Thank you very much. Standing on. So as I said, we're going to do it all at the end with coming together. That's all right. So next up is Medtronic. So just to clarify, the pictures have been put in order of alphabet. It's not in order of just in case anybody has any worries. How would you introduce yourself while you're hitting this up?
Yes, so my name is Mark. I'm a technical consultant working for Medtronic, so I'm a registered nurse who covers central London to facilitate the NHS in the adoption of putting people on pumps, training doctors, nurses and patients.
Did you say you were a nurse?
I'm a registered nurse, just completed my revalidation.
Immediately ahead of others in the love that you're going to get from the room. Is that right? Am I right? Yeah? Oh, okay, don't sort of put in the mum wife's a nurse. I'm pretty sure that will count. All right, good. So, whenever you're ready,
There we go. Excellent. Okay, so very nice to see everybody here today. Thank you for coming along. And this is, of course, Medtronic's presentation on the rise of the machines of the Terminator. Okay, so Medtronic itself is a very large global company. So just a bit of background about us. We have over 88,000 employees around the world, and 9,000 of which are scientists and engineers working on new technologies, such as some of the things that we've got out and other ones that are in the pipeline. We've got 400 clinical trials ongoing, roughly, at a given moment as well. So you will find a lot of research is sponsored by Medtronic. We do quite a lot in that area. And by our calculations last year, Medtronic products, not just diabetes ones, touched 65 million lives. So we are quite a large company out there on a global perspective. And as you can see by that map, we really don't have a part of the world we don't have some sort of presence in. Our top headquarters, our main one for Europe is in Ireland, and we've got our main headquarters, the mothership, as we call it, is in Minnesota in the United States, whereas it all started in a little garage in 1945. So this is where the origins all come from. 160 locations, as we say there, across countries, 480 locations and 89 manufacturing facilities spread around the globe. And what they're all making over the years has been this equipment. I'm sure everybody recognises some of this as well. So we do consider the technology that Medtronic does go all the way along from, we're looking at pre-diagnosis of diabetes all the way through all the different care options along the way. So people may have started on multiple daily injections, and then we had our first insulin pumps come out. So it started off as a very basic one, and then we came up with the VO, which are the first sensor-augmented pumps. So again, this is a lot about the technology, so we're going to be talking quite a bit about continuous glucose monitoring today. So low glucose suspend, just to explain, this was the first pump that when you combined it with the continuous glucose monitoring sensor, when it detected that your blood sugars had hit the hypo range, it switched off the insulin as well as making an alarm. So it was kind of the first automated treatment towards preventing hypoglycemia. It limited the time somebody spent in hypoglycemia and made it easier for them to come out of it. So real clinical applications. And then, just over 3 years ago now, we had the release of the 640G, which was the first pump in the world to have an onboard artificial intelligence system called the Smart Guard. So it is actually capable of taking the information that a sensor gives the pump, and rather than just waiting until something happened when somebody actually hit hypoglycemia, the new algorithm can predict hypoglycemia. So when it thinks the patient wearing it is going to hit hypo, it will suspend the insulin 30 minutes before that point. It continues to watch the glucose levels on the sensor, and when they start to creep back up due to the insulin suspension and it detects go back at a safe level, heading upwards, it restarts the insulin automatically as well. And all of that can be done without a single beep. So it's very good overnight. You're not getting woken up if you need to do anything. The pump does it all for you automatically. I was going to say something else then, so it's completely fled. So yes, that's low glucose suspend. Our first trials of this showed consistently effective about 76% of the time over the complete 24 hours. So immediately by adopting the system, you can reduce your hypoglycemia rates by about 76%. So it's an obvious big thing, but we work with the NHS to get as many people who need it as possibly can. And then we can see further along the loop, we've got obviously out in the United States, that's the 670G, and we're aiming, as we call it, to get the closed loop run. We call it Medtronic, the virtual pancreas. We want to be able to get a device that's going to replace all that functionality to take the real work out of diabetes and just have the machines do what they need to do. Okay. So, we don't just do pumps in Medtronic as well in the diabetes area. We have various items. We've got the new Guardian Connect, which I'm going to talk about in a little bit more detail. We have CareLink, which is our dedicated downloading system, which is also now cloud-based for the Guardian Connect, so we've got lots of connectivity where you can download all your information at home, and your nurses, healthcare professionals, can access that in the hospitals or wherever they are. So it does enable a bit more remote monitoring. I've got some units I work at that do webinars. We talk to people over Skype instead of dragging them into the hospital all the time. We've also got wearables, obviously, we'll be getting some of those. IBM Watson is one of our bigger partnerships that we're doing. Has anyone heard of IBM Watson? They're back there, thank you. So this is basically supercomputing. So we're really working with IBM Watson for the use of metadata to enable us to design more intelligent systems, more intelligent bolus calculators going forward. So we're not just relying on the same information, we use trends automatically. And obviously we've got a range of continuous glucose monitoring equipment as well. Okay. And of course, it's not always just about the products as well. Medtronic does enable a lot of support as well. We've got our 24/7 replacement service for pumps, which fits closely in with our 24/7 product support. So 365 days a year, 24 hours a day, no matter what's happening. If you call the Medtronic support line, you will get a trained professional on the other end who will be able to help you out. And if the product is not fixable, they will ship a replacement. Okay? The MiniMed Care website is an excellent little resource. We've popped everything to do with Medtronic diabetes on one website, so you can get your CareLink downloading, you can order your consumables. We've got blogs from various individual bloggers. We've got FAQs, questions and answers that we've done, and even a little online education system where you can go over the pump again in a little virtual pump in the corner. You click all the buttons on once you started, so you can get a bit of practice or show anyone else you want to know how to use the device, the basics as well. That links in with a lot of the online resources and education. And of course, without sounding too big-headed as well, Medtronic's got us on the ground. We've always got nurses in every territory and dietitians. So if anybody does need a bit of extra support, either it's the nurses or the patients or both, we're always happy to go along and help out. Now, talking about continuous glucose monitoring, of course, it's the access. Can I get continuous glucose monitoring to go with my pump? And this is a bit of work Medtronic's been doing across all the CCGs in the UK. You can see 2016 on the left there, and basically the usual coding. Green is good, red is bad. So the green ones, we discovered either had a policy in or were considering one to make a pathway so people could access continuous glucose monitoring. And the red ones, we either didn't have any details or they weren't working on such a thing. So we've been working with them in my own territory in London. We've worked with the North West London network. We're working with the Pan London group to get these policies into place. And you can see by 2017, we've shifted a lot more areas over to the green. Still not perfect. We've still got large bits of red. We're still working with a lot of areas, but we are pushing it forward. I've been working with Medtronic for about 3 years now, and if I think about the access to continuous glucose monitoring even 3 years ago compared to what it's like today, it is improving. So we're continuing to do this work behind the scenes. And this really just shows our 3 main continuous glucose monitoring products that we have at the moment. So I don't know if anyone's ever used the iPro system. This is the one we have in hospitals. So this is the only blinded continuous glucose monitoring system. So this is what your nurses might put on you to say what your responses are to insulin, how you're doing. You don't actually see it, so there's no way to interfere with it. You get a nice steady reading, and it can show up where areas need improvement. Some of the pathways require one of these to prove there is hypoglycemia before they go onto the pathway and then provide it. The 640G, as I've already covered with the SmartGuard, its intelligent system is able to prevent hypoglycemia by suspending the insulin, as well as it can also alert for highs, it can alert the lows if that's something important for people, but largely it can do it pretty silently. And the Guardian Connect is a new device out. You may not have heard of this one so much. This is our mobile platform. So you wear exactly the same sensor with a slightly different transmitter that pairs with a mobile phone instead of a pump. So if you're already wearing a 640G, the SmartGuard is probably the front line because that will take the action without having to notify anyone. Whereas the Guardian Connect, if you're still using pens or if you're on any other pumps or any other devices, the Guardian Connect can communicate with the mobile phone, so you can see all your highs, lows, trends. You can tell the system how much insulin you're taking, if you've exercised, all downloadable on CareLink and viewable. And again, up to 5 care partners, as we call them, can actually follow this information as well. The good thing is you only need an app on the phone for the user. After that, CareLink can be accessed from any other online device. So if you sat at work on a work computer, all you need to do is open up a browser window and you could follow the continuous glucose monitoring for anyone that people are using that system. And you can also set alerts and alarms to be notified of your highs and lows. This system also has an option in, so if somebody did say they were hypoglycemic and it went on for too long, so you'd set an alarm trigger at about 10 minutes of no action if someone's hypoglycemic, it will actually pop up a text message to the care partners as well, so they don't happen to be looking at the device at that time. They will get a text message saying your person is in hypoglycemia, and then they could call them up, make a check from that remote monitoring. Okay. All uses the same sensor, so the accuracy rates we have with our sensor, I think the Guardian Connect system had we call it the NERD, I'm calling it the statistics, dirty word. It's about 9.1% overall for our system, so it's a nice accurate system as it has to be if it's going to be stopping and starting your insulin automatically. Okay, and I believe we are fielding questions at the end. So that's okay.
Thank you very much. Thank you. Okay, and the last but never the least, we have Roche to do their bit, which will take questions. So thank you very much for coming along and getting your presentation.
Well, you'll be glad to know I have no slides, so we're breaking the rule. I was very happy to see my other industry partners here having beautiful slides, and me coming up with none because as I'm finishing the session, it makes me go to the point probably quicker and get to the panel discussion. So I will introduce myself. My name is Françoise Lepolichet. I am talking today on behalf of Roche Diabetes Care. I work in the global office for Roche Diabetes Care in Germany, Mannheim. I've been working there for the last 3 years, and prior to this assignment, I was actually based in the UK for the last 7 years, where actually I was managing the insulin pump division for Roche on the UK market, and this is where my history is. From a personal background point of view, I'm a person with type 1 diabetes, and that's also why I've got this passion driving me when it comes to technology uptake for patients and the overall status or challenges of the healthcare professionals and healthcare environments. So just so I know who I'm talking about, who is wearing a pump in this audience? Yay. So the good news is that I probably don't have to really introduce my products. We have 2 pumps in Roche Diabetes Care, the AccuCheck Combo pump and the AccuCheck Instant pumps. And one of our point of difference when it comes to pump therapy is about remote control of your pump therapy through a handset. From a technology point of view, one of the key things I wanted to say today is that we have been working on a lot of topics for the last few years, talking to a lot of our patients that are actually telling us, to be frank, I love the remote control, but I want a lot of this on my phone right now. So in terms of new news to actually announce today, at T1D last week we presented our future pump remote control for our AccuCheck Insight pump. We are starting the process and the journey in terms of developing this, and we actually really believe in the growth and the progress of digital, because a lot of the data will be coming through smartphones, and as explained by our Dexcom colleagues, there is a lot of information that in the future will be managed through the smartphones. What I wanted to say today is my UK team here spoke to me about this initiative put together by Tech UK and NHS England, and I was really personally very interested in being here to hear about patients, healthcare professionals, industry, and healthcare systems coming together to tackling the challenges of people with diabetes. At our level, at Roche, we are engaging a lot at the moment with the JDRF at global level, and I know we will have a talk from the JDRF in a few minutes, but this is one of the reasons why I wanted to be here, is that we actually really believe in supporting a lot of the patient work and the do-it-yourself community work which is happening at the moment to accelerate the uptake of artificial pancreas system in the future. We believe that there's a lot of challenges. We're very happy to see Medtronic with their first closed-loop system in the market. But seriously, as mentioned by Kowalski last week at ATTD in our Roche symposium, we really need to accelerate. We need to have various solutions. We need to have much more access for this system going forward. So one of the reasons for me to be here, and the reason why I have no slides, is that we're very busy driving a lot of our projects to really come up with solutions at European and global level. But one of the reasons I wanted to be here was really to listen to the debate, listen to the exchange, start, being part of this conversation, because I strongly believe that it's going to take a lot of efforts from core health organizations, industry, regulators to help us, first of all, bring more products faster to the market, but get acceptance through the system. Having worked in the UK for a lot of years, we can bring as much technology as we want as an industry, but if we don't have the healthcare professionals actually in the hospitals that are trained, having to look after the patients, dealing with technology and getting to looking after everybody, we're having major challenges. So we're engaging. I can speak now that I am in a global position about the differences about access to care in the UK. Being a patient, I've been living in the UK for 20 years, so I have my own personal experience. I know about the NHS lottery or whatever you call that, but the fact that if you are in a good area that supports pump therapy or CGM, then you are quite lucky. But if you live in other areas, then it's more challenging. And now that I personally live in Germany, I can see the differences. I have been lucky to get an easier access to CGM reimbursement in Germany. I can see the difference in the different countries and where we are actually rating or standing in the UK. I'm very excited to see this initiative because it's going to take all of the efforts from everybody to get to where we need to be. So from a Roche point of view, we're very focused on our insulin pumps, and that's what I manage now at the international level. I'm engaging with people like Dana in the back of the room and a lot of the people from the do-it-yourself community also to listen to what the community is doing. I mean, it's absolutely unbelievable, the stuff that they've been creating, and we're very excited to see this. On the other hand, it's a bit staggering. Why should patients have to do this by themselves? This should not be their role. It should be the role of the industry and everybody to make this happen. As a company, we're very interested in supporting the JDRF in their efforts. We're very interested in engaging with the patient community to get some learnings and see if that can help us accelerate bringing new products to the markets. And we're just really interested to see if we can actually challenge the regulators in Europe and in the USA and find a way that we can all get better systems for us. As a philosophy point of view in Roche, we believe that people should be able to choose the pump that they want, the one that they choose for a variety of reasons. We believe that they should be free to also choose the glucose monitoring device of their choice. I mean, we in the UK are distributing the Eversense sensor, which is a fantastic sensor. We think that people should be free to choose what is working for them. And in the future, we strongly believe that algorithms are really going to help us managing type 1 diabetes going forward. So I'm happy to take part of the panel discussion, and you can speak to me afterwards.
Thank you very much.
Hello.
So I'm going to ask the four speakers to come up on stage, and we'll have one roving mic for the audience, one for the panel. We'll take some questions. The break's at 11:30, so we've got about 15 minutes or so. But there's panels through the day, so worry if you haven't got your question in. You can also, I'm sure, over the break, hound them more if you want to. So before we go to the panel, one thing. So how much do you think, I'm not even going to go to pumps for a minute, I'm just going to talk about continuous glucose monitoring. How many people do you think you have got type 1 diabetes in the UK? Anybody? Take a number. 400,000. Very good. Roughly, give or take, according to roughly the estimates. How many people, according to data, or according to science and research, should be on a continuous glucose monitoring? Anybody? It's about 20%. Somebody said everybody. Let's go with 20%, which talks about hyper awareness, which is where continuous glucose monitor should sit and all that. Correct? Anybody correct if I'm getting things wrong? Right? Hold on. We're just going with that because I wanted to get the number down to 20%. Okay, so that's 20%. Hyper awareness is 20%. I'm just going with what NICE have started off by saying. We'll talk about the evidence coming through in pregnancy and stuff later on. But let's start with hyper awareness, 20%. How many people is that? 80,000. So somebody's done their grade in maths. Very good. Average cost of a CGM is about £2,000 a year, right? That's 160 million pounds. Okay? If I had 160 million pounds right now, let's say we had a fantastic meeting with Jeremy Hunt. So we lobbied a lot for a couple of years to get 40 million pounds for the whole of diabetes. So this year we give 42 million pounds, which has sent ripples of excitement through the healthcare community because it's never happened. Ask some of the clinicians in the ground, 40 million pounds is a bit like manna from heaven for a lot of people. The question is, if I had 150 million pounds, would we be able to I know the answer to this, and if you read my blogs, you'll know my answer to this. Would we be able to justify giving £150 million only into continuous glucose monitoring? Do we think money is the barrier? And we'll ask, you don't have to answer this question because we'll talk about those in the panel later on, where Anne and others are going to join me. Because I want those conversations to happen. This is not me saying it's not going to be available, because you all know what I'm working towards and what I'm trying to do. But is it just money? Do you think if let's say we had money and we said, right, everybody goes for continuous glucose monitoring, only 20%, we're not even going to go anybody else. Do you think this country is ready for 80,000 people with continuous glucose monitoring?
Yes.
Somebody said yes.
People with diabetes are, clinicians may not be.
Do you think 80,000 people with type 1 diabetes are trained enough to look after continuous glucose monitoring?
They are trained.
Okay, anybody would like to differ with that? Tim's put his hand right up from the back saying, and I want you to hold that thought because we'll come back to that. And we will come back to that to have that conversation because the answer is yes and no. Sorry, Anne, you wanted to say one thing? And just putting some numbers down for you to mull over because it's not just about the money. So the question is, I'll give you one thing. Oh, I'm going to take that question. Please, go.
Please, it's not so much a question, but it's also not just whether people are trained, but the confidence they have in the things, in the technology, I mean, because they look at statistics and see that, say, I don't know, I'm just making this up, but 40% of people aren't getting good results. This is completely made up, by the way.
No, that's good. You're very far off. Carry on.
And they think, oh, well, actually that's quite a big statistic.
Mm-hmm.
And is it worth it? And actually, because we've only got a certain amount of people who are trained, and they, I don't know, don't think that it's worth it.
So you're right. None of them should be barriers to people getting it. Because when you're sitting there with your own type 1 diabetes, all these statistics becomes slightly irrelevant, doesn't it? Because you're going to I get all that. But I need it. Yep. Do we have that debate when it's a cancer drug? Is it because it's more emotive? Is it because it's not that relevant? Or is it because diabetes is all about eat a little bit less cake and you'll be fine? It is the consensus in the media thing you're also challenging. Correct? So there's a lot of things that need to sort of change. But I can also tell you that money is there. The barriers are not simply money. There's a bit more bigger than that. So we'll talk about it in the day, but I just want to start there just to put that thing through. So I've asked you to be nice and polite, but not to be completely dormant. This day is to challenge. We're here from a policy point of view. There are clinicians in the room. We've got Reza from all the way from Liverpool to come here as well, because that's the level of interest clinicians have in this as well. With you all living with it, there are these guys who are doing the work. And obviously we'll hear from Dana and others later on. So, without further ado, questions for the panel? Anybody? Right, we've got a hand straight up, right, and at the back, right, here we go. First up. Do you want to just say who you are so we know at least, so we can all hound you if you ask a really difficult question?
My name's Sarah and I've come from Birmingham today. My question is, how quickly can your software developers respond to user feedback? So, for example, if you had a CGM device that you weren't able to calculate insulin doses directly on, to be able to add in an insulin calculator, or if you had a pump that you weren't able to manually enter glucose results, you had to use a certain glucose meter, and then you changed it to being able to manually enter. How quickly can your software developers make those kind of changes?
Anybody who wants to take that?
I think
You are
an
ready.
R&D person.
Why don't you move it around? Yes.
Sure. As the R&D person in the panel, I think software developers, all of the companies here have excellent teams of engineers and software developers, and putting together solutions like that isn't terribly challenging. It's testing it. It's the regulatory environment around making changes like that. Developing that is exactly the expertise that these companies have. You used a a broad variety of examples, but each company on the panel here has excellent engineers and software developers who can address these challenges.
I think it depends on the type of products. So, for example, you can see that Dexcom can launch G5, G6, faster than a new pump. So you're going to go faster in terms of the feedback or the development, depending on the platform. And for us, in an insulin pump, when we have to change a software, so I don't know, open a bolus device or do something technically in the pump, it's going to take a little bit longer. But again, the software development in itself is not the time-consuming element. It's all of the verification, validation, and documentation that takes a long time.
If I can add, we certainly listen to the voice of the customer. We're very interested in the feedback. I think you see that in a product like Freestyle Libre. I mean, we have part of the reason for showing the history of products that we made is that we hear the customer. We're very interested in it, and we think we've taken that into our ethos, and we create products that we think patients can use, patients want, reduce the burden to people with diabetes. From the last question, that getting rid of some of the complications of using a device, getting rid of calibrations, having a device that you can wear for 14 days is addressing some of those things. Again, the software changes themselves. That's what these companies are good at doing. Yeah.
We had one question at the back, and then we'll come back to you, if you don't mind, then an Anne. That's all right.
Hi, I'm Abby. I have type 1 diabetes and half work in tech. Practicing scientist, so cool. Yeah, feel sorry for me, I have no money to. My question really, as someone that works with industry as a scientist as well, I'm not sure how open you are with patents and tech and code, but in my mind, as the selfish person with diabetes that wants everything, would it not make more sense to share? I know it's a competitive market, but do you share between companies? For example, Medtronic doesn't have the remote bolus system, which really is the drawback for a lot of people, whereas Roche do, but Roche don't have the integrated closed-loop software. So yeah, my question is, how open are you to sharing?
I'm not sure it's about sharing, but it's about the technology and the platforms. So one of the motivation for us, I mean, I can only speak for Roche, of course. One of the motivation for us in terms of moving our remote control to a digital platform, mobile phones, we know it comes with a lot of regulatory hurdles, because in our case, compared to Dexcom or Abbott, which is about viewing the data, for us it's about controlling an insulin delivery device. So in terms of the regulation, it's still a challenge in terms of making this approved. But one of the motivation for us to make that transition from a proprietary device to a app platform is that it makes us much more flexible in terms of the integration of the device from the other industry players. So the vision is that once we have this app, we can integrate data from a variety of parties. And because it's digital, it's much easier to speak to Dexcom, speak to Sensionix, speak to glucose monitoring devices, to integrate there. So we're really hoping that the digital movement is going to allow us to be faster and bringing more flexibility and be more open. So it's not so much about the sharing, it's about building the technology platform that allow us to speak in an easier way in the future.
And just on that one, I think it's also important to remember that if we do share everything amongst each other, we'll end up with a lot of devices that all do the same thing. And I think it's quite important that different companies have different focuses so that it enables a lot more patient choice. So
I think it also, I'm giving an analogy here, Formula 1 racing would be incredibly boring if everybody shared all their secrets with each other, I suppose. It is a competitive market, I think we forget that, and I say it tongue-in-cheek, but I think there is a question of sharing the basics together, and I think some of it will come through in Dana's presentation, which I'm not going to steal the thunder of. So, for the one interest of time, yes, we'll talk about CTM being more than 20%.
I think to your analogy, Partha, with Formula 1, it's about one company winning.
Mm-hmm.
For us, it's about us getting the fastest car as quickly as possible and getting everybody working together on that. So my question is about open systems. I think one of the problems that you all share is the amount of bureaucracy that you have in dealing with getting products through trials. One of the easiest ways of dealing with that is by focusing purely on unbundling the technology that you've got around that and focusing specifically on doing insulin delivery rather than having proprietary systems for bolus calculators and that kind of thing, which is all relatively vanilla now and is already done through software that's evolving on a regular basis. My question is, how do we work together to get you all working in an open systems framework? So, for example, we don't have to reverse engineer pumps in order to be able to deliver insulin through those pumps.
I was wondering when the difficult questions would start.
With me.
Okay, so I can speak for that one because that's a topic that we've been debating, especially since the JDRF put their open protocol call to action at the end of October last year, and we're quite advanced in our discussions there. There's a variety of angles to the questions. There's one technical topic, which is about creating open protocol communication between the various parties so that everybody can speak the same language and the device can communicate. That's the technical hurdle, which is something that can be addressed. I'm not saying super quickly, but it's really the easy part. The most difficult part as part of the JDRF Open Protocol initiative is about the legal framework, the regulatory pathway, and the clinical evidence generation for the adoption of those systems in the future by the healthcare community. So as far as again, I feel like I'm speaking on behalf of the JDRF, but that's because of my involvement with them. I understand all those topics now quite a lot. It's going to take more than one company to do that. We can take care of the technical bit. That's fine. I can decide to give a job to my R&D organization to modify the pumps. But the bigger picture is like, how do we define a new legal framework for open source adoption? How do we define also a regulatory pathway? Because that's a big, big topic. And the next challenge is the clinical evidence, the clinical trials to make sure that all of these systems are safe, secured, and documented. So it's quite a big, big topic.
If I can just add to that, it's non-trivial for the algorithm developers to say what are the minimum performance standards that they require for the individual components. So it's one thing to say I've tested this system, but what are the picadillos of that system that enables it to work, that would it work with the next pump or the next sensor? And there's challenges that, it's certainly non-trivial to point out what are the minimum performance standards that you need that allows that interoperability to exist. I think we're just starting to come to terms with some of those questions.
I think for me, if I'm very honest with you, I mean, this is a quantum leap in the sense that at least people are coming around the talk. I mean, I have been in meetings where it was a complete knock it out. It's not even a topic of discussion. And I've been in those meetings not that long ago. And in the course of the day, I mean, yesterday I had a big conversation with Dana about what the next steps could be, where the blocks are. So we'll talk about it during the course of the day. But I think I would say is that I don't think 2 years ago you would have had a scene where you had all these 4 companies sitting around and taking questions. And I think that's a step forward. These things take time. But we're getting there. I think the organizations such as JDRF are trying to push it, and that's the right direction. We will get there, I reckon. Companies will have to do their whole regulatory, and there is a degree of frustration. As you said, I don't have type 1 diabetes. I keep on saying, I have no idea what it is to have a hypo, right? So I will never get the frustration, in spite of all the rules I would do. But it is about the pace that we are quite keen to work with the companies as well on a policy to push that pace. So everything you guys are doing, carry on doing. The voices are being heard. Do it with respect, and it will happen with time. Anne, you had a question.
I'm also the Chief Nurse at NHS Digital, which gives me a very unique perspective. What I'd like to say first of all is I completely respect some of the things that you're saying about the regulatory framework, about standards, about safety, and actually I've learned over many years that they're really important things and that we can't really shortcut them, and we have to have them in place. It's very easy for an algorithm in a piece of software to send things going in completely the wrong direction. question, but I also would like to say that I do support open APIs and the open source initiative in general terms. But what I'd like to ask is a very different question, which is around, I get incredibly frustrated about I also want you to compete with each other, because I think that's the way that we get the best. So I agree that's a good thing, which is Partha's point, really. But I get incredibly frustrated about the lack of connection with real people like me in your organisations around your development cycles, and it's really opaque. I can't see how you're really engaging real people, like the people in the room, with what you're doing. Now, I understand that that's proprietary, but I'd like to understand more about how do you do that, and how do the people in the room help you get your products to the best place that they can be.
There's a room full of people whose emails I can forward to all of you.
So I think it's a great question. You know, we work very closely with patient groups, with user groups. We do a lot of human factors work. We work very closely with the patients. We work closely with doctors and nurses, and it plays an important role in our development cycle. And our product doesn't develop past those initial stage gates without going through all of those steps. So we're very interested in. I'm happy to give my email address.
Happy to give your email address too.
Absolutely.
You have no idea what you're walking into. Okay. Ollie, does he know what he's doing? No. Ollie's
I already get those emails.
All right, Donald.
Yeah, we're very similar. I think we'd all be broadly similar. You know, we have focus groups. We try and work as closely as we can with the charities. We very, very interested in your guys' views, because it drives innovation. I was at a meeting yesterday that some people were telling me that we hadn't thought about, and what's important to you is important to us, because it makes the functionality of these products. That's where they sit. So if you guys have got some great ideas, please share them. And my job is really is around reimbursement, and I think whatever you guys, your voice is huge. Companies, we can put files, dossiers, whatever you want together, but a lot of it comes down to what you guys say, the feedback that you give to DK, to GDRF, and advocacy that you can push to NICE. And NICE really do take on. I've got to put a lot of onus on what you say, and so please don't think that we sit here with closed ears. We really want to engage with you guys. And
good. So we have a clear commitment that they're willing to listen to the common people, right? Which is good. Excellent news. The commoners. All right. Well, we've got quite a few questions, and I know there'll be a time for breaks. So I'm going to actually get the questions into short answers. We might eat a little bit into coffee break, but I suppose you can all have coffee later on and outside. The whole point of this is so you can have the opportunity to ask these questions which you won't normally get. Yourself.
Hi, I'm Ian. I'm a technical diabetes. And I work in health economics. And in terms of sharing secrets, I know that's one issue, but are you doing any work to go to the NHS and say, we can package this kind of care pathway together under one price, rather than saying, if you use a CPM, then your HbA1c will drop by a certain percent without considering all the other steps that are involved in between?
I'll take that. Yes, the answer is shortly yes. So those are conversations we are indeed having. So we can't obviously make that public right now but yes. So I think I'll be very clear about it. All four companies here, right, have been very open about working in a different way. So we've made a lot of suggestions, and I think we should have a brighter future than what we have if we can hold to that. So the answer to your question is, and the other thing, Liam, I was going to come back to you anyway, because of we knowing each other about the health economic side. But yes is a short answer. Companies have expressed interest. There are different projects we're all working on, looking at. It's not just a simple, just pay us and we'll see how things go. Okay, so that's an answer to that. I've had a question here. There.
Hi, I'm Steph. I have type 1 diabetes, and I'm also a fellow nurse. I know there's a few of us in the room today. My question is about going off record. So obviously with CGMs, pumps, there are unofficial apps. There's obviously the DIY artificial pancreas. And the main reasons that I think people do this is to better their life with diabetes, understandably, and also cost. I'm just wondering what your views are, and I'd like you to be as honest as possible.
Okay.
People using those.
Who wants to be as honest as possible?
It's
not a drinking game, so...
Yeah. It's a very interesting question, and a lot of the conversations have been about regulatory approval, and I think we quite rightly are operating in a very in a regulated environment for patient safety purposes, and I think that's very, very important, and as companies we take that responsibility incredibly seriously. But that said, as the panelists mentioned, we see some great innovations, and we think, my goodness me, that's the industry really, we need to we look at these things and think, can we do this? But it's got to be within the confines of the regulatory environment, and it's for patient safety that we hold very, very dear. And I think so. I hope so. Is what we'd say. So.
I mean, we're very aware and informed, especially recently we engaged with all of the people that you'll see or talk about this afternoon. From an insulin pump manufacturer point of view, I'm in a different position than, a glucose monitoring device. And our level of responsibility, and I speak to you as well, is that the big problem for us as an insulin pump manufacturer is that we're the ones responsible if something goes wrong. And me, since I've been in a global organization, I'm in charge of the quality management system. If I have supporting, that's why we are desperately motivated in working with the JDRF to really find a way, because unless that's happening, I'm in a risky situation, and that's the challenge. That's a big challenge that I have at the moment, is about this. If something happens, the legal responsibility is going to come on my product.
Can I just ask you a question? You're a clinician, right? Forget your type 1 diabetes hat for a minute. Patient comes to you using a rig, and you look at it and you go, I have no idea what the heck this is. What's your first reaction? Are you uncomfortable with your patient? Don't put your type 1 diabetes hat on, just as a clinician. What's your view?
Yeah, I mean, as a nurse, I work in public health, and I'm delivering health messages, and I follow guidelines and tell, the children and families I work with, this is the guideline.
Yeah.
So when they don't follow that, I do think, okay, well, whatever you're doing is at your own risk and your own health.
I think.
But obviously, and then I'm told the guidelines for type 1 diabetes, but do I follow them properly? No, because.
So here is the problem. I think companies are no different from that. Okay, and I'll be very honest with you. I've got patients, some of them in the room, who come along as I'm using this, and I've got a very simple way of doing it. As I said, I don't have type 1 diabetes. Is it working for you? And I go, yeah. Are you well? Yeah, great. Carry on. Fine. That's as simple as I do type 1 diabetes. I don't care what you use, right? As long as you're not saying something like, I've stopped insulin, taking cinnamon, and it's all I'm okay, right? So my job is to keep people safe. It's not to interfere if something's working. Safety is my job, right? If somebody says, I want to try X, my only thing is to say, here is the data about safety. Your call, you're an adult. Or you have got a parent who's an adult to make the decision for you, but you're all trying to do the right thing. So that's, companies are no different from that, is that way I look at it. So that's the sort of crux that we're caught in. And we'll take one more question, because the gentleman, probably, if you catch up with them after the break, if that's all right, or we can ask it in between, all right? Super quick, you're going to do super quick. I'll have this gentleman, then you are the super quick.
I can try and keep this very quick, because this is more of a statement than a question, but it feels like a good opportunity to make it. I'm James. I have type 1. I'm not a healthcare professional. But what I think is really important to say, and this is personally important. I can't speak for others, but a lot of what you guys are saying in terms of the technology is that you're trying to make things as simple as possible. So you're saying we can take away calibration from CGM, we can take away the number of finger prick tests you have to do a day. If you go onto a pump, then it means you can take injections out of your life. It's about kind of trying to simplify life for people living with diabetes. For me, actually, I don't care how complicated life gets. I put huge amounts of effort into trying to manage my blood sugar. What really makes me despair at times is when it doesn't work. It's the frustration. So actually, if somebody said to me, if you do 10 finger prick tests a day, you'll achieve great control, I'll do 10 a day. If it's you can have CGM and you'll have great control, I'll pay for CGM. If it's you can use this pump and set it up right and you'll have great control, I'll use it. But actually, it's not about the simplification. It's not, I don't want to remove any kind of interaction with diabetes from my life. What I want is that the ones I choose to make are the right ones and they deliver the right results for me.
All right, thank you. Thank you. Very important one. Quick question. Super quick question.
Super quick question. Two. Really quickly, I just wanted to know Freestyle's view on BlueCon and turning Freestyle the flash monitoring into CGM, and also whether or not Medtronic are planning on any tube-free. I'm an omnipodder. I hate tubes. Get rid of them.
As your feedback, get rid of the tubes.
Yeah. Traditionally, Medtronic's always used the tube systems. It's what we're good at, and it's the line that the company has decided to go down. We don't have any plans to make a patch pump, but like I say, if we all made patch pumps, we all need tube pumps, we wouldn't have much choice. So we're continuing down.
Good, thank you. And Abbott?
To me, your question is a lot of ways the same as the question that preceded it. To me, safety is the first thing. It's my responsibility. It's my number one responsibility as a product developer. And I know what we put into our Freestyle Libre system. Lucom doesn't know exactly what we put into our Freestyle Libre system, so people are taking risks when they use a product like that.
Okay. All right. Okay. We'll take a break. I know we have already eaten into your coffee break, so can we do a what do you say, Ben?
Just 5 minutes.
You won't be able to do that in 5 minutes. It's impossible. Try to use the toilet and use it in 5 minutes.
Our attention to
No, it's fine.